And we do want to thank all of our witnesses for being here this afternoon and taking the time to testify before the subcommittee. Each witness will have the opportunity to summarize their opening statement, followed by rounds of questions from the members. And this afternoon, for our fourth and final panel of this two-day hearing, we are going to hear from Ms. Jessica Hulsey-Nickel, founder, president, and CEO, Addiction Policy Forum, Ms. Carlene Deal-Smith, peer support specialist, Presbyterian Medical Services, Mr. Ryan Hampton, recovery advocate facing addiction, Dr. Mark Rosenberg, chairman of emergency medicine and chief innovation officer, St. Joseph's Healthcare System Board of Directors, and the American College of Emergency Physicians, Ms. Stacy Boland, CEO of the National Indian Health Board, and Ms. Alexis Horan, vice president of government relation, Clean Slate Centers. Again, thank you all for being with us today. Ms. Hulsey-Nickel, you're recognized for 5 minutes, please.
Thank you so much, Chairman Burgess and Ranking Member Green.
Gentlemen, would ask the audience to please be seated and allow our panel to be heard, If the gentleman does not sit down, I am going to instruct Capitol Police to remove you from the hearing room. The gentleman will sit down. Gentlemen will be seated. The gentleman will be seated. The gentleman will be seated and allow our panel, who we've invited. The gentleman will be seated. Can I ask committee staff to ask Capitol Police to give us some assistance in getting the gentleman to be seated? Ms. Hulsey-Nickel, you're recognized for 5 minutes. Testimony. Dr. Rosenberg, you're recognized for 5 minutes, please.
Thank you, Mr. Chairman. My name is Dr. Mark Rosenberg, and I am chairman of emergency medicine at St. Joseph's University.
Dr. Rosenberg, may I just ask, is your microphone like?
I'm sorry. My name is Dr. Mark Rosenberg, and I am chairman of emergency medicine at St. Joseph's University Medical Center in Paterson, New Jersey. I serve on the board of directors of the American College of Emergency Physicians. So on behalf of St. Joseph's University Medical Center and its 170,000 visits in the emergency department per year, the 38,000 members of the American College of Emergency Physicians and the great state of New Jersey, I would like to thank the committee for this opportunity to provide testimony in support of two bills, ALTO, the Alternative to Opioids in the Emergency Department Act, and POWER, Preventing Overdose While in the Emergency Room Act. There are two cornerstones to ending the opioid epidemic, prevention and treatment, and they are represented by these two bills that I am supporting today. The prevention program is Alternative to Opioids, or ALTO, and the treatment program is MAT, or the POWER Act, and both are necessary to stop the continued opioid misuse, abuse, and overdose. Prevention, HR 5197, ALTO, was developed by my team at St. Joseph's University Medical Center in New Jersey in 2016 to address the variation in prescribing habits and to decrease the reliance on opioids by emergency physicians. We started the program with a very simple premise. The best way to avoid opioid misuse and addiction is to never start a patient on opioids. The ALTO program is evidence-based protocols using non-addicting drugs and therapies that target receptor sites and enzymes that mediate the pain. An example is a patient with back pain. Instead of giving them opioids, I give them a layered treatment of therapies that include non-addicting medication and trigger point injections, resulting in better pain management and improved patient experience of care. I am proud to say that after 2 years of implementation at St. Joseph's, the ALTO program has witnessed tremendous success. In the first year, there was a 57% reduction of opioid use, and by the end of the second year, there was over an 80% reduction of opioid use. These statistics reveal that education evidence-based clinical treatment protocols can have a dramatic impact on the fight against opioid addiction and overdose. More importantly, ALTO program can save lives, and already there are emergency physician acceptance across the country to use ALTO protocols. Emergency Department initiated MAT, or medical assisted treatment, represents the treatment arm of the equation. Let me give you a moment to tell you about every single patient addicted or dependent on opioids or heroin fears going into withdrawal. Patient in withdrawal experiences a feeling of being sick with chills, sweats, GI symptoms, and agitations. These patients either have to do another dose of opioids to stop the withdrawal, or they need medical assisted treatment to stop feeling sick and stop the withdrawal. ED-initiated medical assisted treatment alone has shown positive results in getting patients to with substance use disorders into addiction treatment. But MAT plus a warm handoff yields the best opportunity for success in getting patients into addiction treatment, as well as decreasing the need for inpatient addiction treatment services. HR 5176 requires that healthcare sites have 2 essential ingredients that emergency physicians would like: providers that are trained and licensed to provide MAT, and number 2, agreements with community providers and facilities to continue services, the warm handoff. We appreciate that Congress has done to help the opioid epidemic. The $6 billion included in the Bipartisan Budget Act of 2018 will be very helpful in turning the tide against opioid misuse. We urge you and your colleagues to not only authorize HR 5197 and HR 5176, but to support full funding of these programs as well. This is one of the biggest healthcare challenges of our generation. It took many years to get to this crisis point, and unfortunately, it will take some time to resolve the epidemic. But we are on the right track. Provide us with ALTO and MAT tools and funding, and emergency physicians will be able to provide a better future for our patients as well as society. Thank you.
Thank you, thank you, Dr. Rosenberg. Ms. Boland, you're recognized for 5 minutes, please. Chair thanks the gentleman. Chair recognizes the gentleman from Georgia. 5 minutes for your questions, please.
Thank you, Mr. Chairman, and thank all of you for being here. You know, I've described the opioid epidemic in our country as being twofold. First of all, we've got that part that is somewhat tangible, that we can somewhat put our arms around. That is, how do you control these numerous prescriptions that are being written, limiting the number of prescriptions, limiting the pills, those things are somewhat tangible. But then we talk about all those millions of people who are addicted now, and how do you deal with that? That's a whole different subject, if you will, and a whole different situation. That's why I'm so glad to see all of you here, and I appreciate it very much. And Dr. Rosenberg, I want to start with you because as the only pharmacist currently serving in Congress, I find it fascinating that I feel like there's a big void that exists right now in medicine. And I've preached this to the pharmaceutical manufacturers that, you know, we have opioids, and once you get past opioids, we really don't have anything else to prescribe. I mean, you got ibuprofen and tramadol, and then you go to opioids, and there's a big gap there. And I've been on the pharmaceutical manufacturers. We need to fill in that gap. And then over my career, I've witnessed miracles come out of research and development, but I still haven't seen them fill in that gap. That's why I'm so interested in your program. And I want to tell you that until this hearing, I was not familiar with it, but I commit to you that I'm going to study it. I do think there's value in this. There are alternatives that can be used, that we need to use, as opposed to just putting people on the opioids. I can remember practicing my pharmacy across from a dental clinic, and they would always give them 3 prescriptions: ibuprofen, pain pill, and the antibiotic. And they would come in and say, "Oh, I don't need the antibiotic, I just need the pain pill." Yeah, right. Well, we finally passed a self-imposed rule. You had to get the antibiotic if you were going to get the pain pill. But really, I'm going to study more, so I want to acknowledge you. Now, I want to go to Ms. Nickel.
Ordered. The chair will recognize himself for 5 minutes for questions. Dr. Rosenberg, I was intrigued by your testimony and your alternatives that you use in your emergency department. There's an ancillary bill. It's not directly related to what you're doing, but it is. It seems to me that it has some connection. Dr. Gottlieb yesterday, when the Commissioner of the Food and Drug Administration was talking to us, talked about the difficulty of developing new treatments for pain, and that the data sets are sometimes vague and indecipherable. And you seem to be doing, though, some work with what you described as alternative pathways. Is that correct? So the bill that actually is only in draft form right now, and it's one that's under development, but it is to encourage the Food and Drug Administration to develop draft guidance for alternative pain medicines and use a breakthrough designation along that development pathway. Again, Dr. Gottlieb referenced how difficult that is in the research and regulatory environment, but you seem to have found a way to make that useful. Is that correct?
That's correct, Mr. Chairman.
What, if I may ask, if it's not proprietary, what is it? You reference enzymes in your testimony.
The principles behind the ALTO protocol is to really increase the number of tools in the physician's toolbox. As one of the congressmen suggested, there used to only be Tylenol, Motrin, and opioids. And if we wanted to guarantee the patient the best treatment, we would give them opioids. Obviously, that was a bad decision. The principles between ALTO and the development of the ALTO protocols was really to search the world literature for existing protocols that existed without the use of opioids. Let me just give a quick example. Renal colic, if anybody had kidney stones, is a tremendously painful condition. But there have been treatment protocols and treatment successes in the literature using IV lidocaine that we used to use commonly for cardiac issues. Now that works tremendously well for people with renal colic. It does two things. One, it relieves the pain, and we have to do more study on this, but it seems like it passes the kidney stone more quickly. So the real secret behind ALTO is finding existing protocols, not going through an IRB, not doing a lot of studies. At least that's how we created it, by taking the protocols that are out there. We use medications like nitrous oxide and do nerve blocks and lidocaine and use patches, but it's a layering of different medications and protocols together to get the maximum benefit for the patient.
Well, I thank you for that. It's very intriguing. Of course, I'm old enough to remember when we had Toradol and Stadol as new medicines.
Yes, indeed.
We no longer have those in our toolbox. Mr. Hampton, thank you for being here.